My discussion is about plantar fasciitis, but a different angle. I want to talk about the surgical treatment and endoscopic surgical treatment with the consideration of portal choice and preliminary clinical results we have with one portal treatment. As was spoken before, plantar fasciitis is a very common heel problem. About 90% do well with the conservative treatment. I want to talk about the other 10%. The pathophysiology is inflammation by microhematoma and micro tears of the plantar fascia. It's very frequent, most frequent in runners and dancers. The etiology is not very certain, but we see a lot of people with cavus foot, obesity, and it's more predominant in women than in males. Usually the patient says they have pain during their waking when they awake, and then the pain disseminates later. With physical examination, you can see that they feel pain in the anteromedial aspect of the heel. There's a lot of DD, differential diagnosis of calcalendynia. We won't go through that. Conservative treatment with extracorporeal shockwave therapy, as was spoken before, with NSAIDs, ice, corticosteroid injections, and autologous blood injection that wasn't spoken about with the conservative treatment. The first classical operation for plantar fasciitis was an open procedure, which includes a very wide excision, more than 4 centimeters until 10 centimeters in the classical approach. At about 10 to 15 years ago, they started with the closed procedure, which minimizes the tissue destruction and disruption. It's reduced the postoperative recovery time, and it allows complete visualization of the nerves that pass near the plantar fascia. It lowered the infection rate very much, and the big difference is the surgeon could see the nerves and the plantar fascia that is sometimes very hard to see with the open surgery because of the mutilation of the soft tissues. The first approach was the Baraday two-portal approach, which uses a smaller diameter endoscope. It was performed more than 500,000 procedures in the United States. The complication rates was reduced to 10% as opposed to 34-35% in the open procedure. And a new complication arose, which is the lateral column destabilization phenomena that was derived from the early ambulation of the patients. So the lateral column destabilization is characterized by pain in the sinus tarsi, in the calcaneal cuboid joint, and a peroneal tenosynovitis. How do we try to prevent this problem? We cut only the medial 1/3 of the plantar fascia. We use quantification of the cut. We cut on average 13.5 millimeters of the fascia, and the instrumentation got modified, and we have intracannular markings on the cannula to see how far or how deep we cut. We also use patient education, and we reduce the stressful activity during the first hour to 6 weeks after surgery. We use for preoperative planning a normal non-weight bearing lateral X-ray of the affected foot, and we apply the points of the portal as we will see later. Fascia, we use 2 portals, two sites to enter. One is the superior portal that allows a better visualization of the nerve, but a difficult point to cut the fascia. The other one is the inferior port, which allows us a better cutting of the fascia, but a lot less successful visualization of the nerve. We can see the inferior port here. This is the skin and this is the fascia. and the superior space between the bone and the plantar fascia here. The preoperative planning is the patient is positioned supine with the bump under his buttocks on the affected side. A tourniquet is on, and we use 1 gram of cefamizine for prophylactic antibiotics. We use ankle block or local anesthesia when we operate. The port of entry is 8 millimeter horizontal incision just anterior to and plantar to the medial tubercle of the calcaneus. The portal is located 4 to 8 millimeters distal to the palpated distal calcaneus cortex and 3 to 4 centimeters anterior to the hindfoot skin. The portal is posterior to the area of the most pain in plantar fasciitis, and this is a very important lesson that we learned because there's a high risk of nerve injury in the more anterior portals. Using the inferior portal of entry site is more posterior than using the superior portal. This is how we prep the patient. This is the incision. In a single portal approach, the abductor hallucis muscle is visualized medially, and the plantar fascia is visualized. The probe is passed through the single medial portal and advanced to palpate the medial band of the plantar fascia, and we see the space between the central band and the medial band. The foot is dorsiflex to place the tension on the plantar fascia, and we use the smiley knife to push across the medial band to cut it. Usually we pass it through several times to cut only the medial 1/3 of the fascia. Here we see the nerve under vision, and this is how we perform the cut using several passing of the smiley knife through the same portal as the camera is introduced. In a post-op care, we ask for elevation for 48 to 78 hours post-op, and medication is is not required because usually the patient don't have pain. Weight bearing is tolerated for 3 weeks to minimize the risk of lateral column pain, and we resume normal activities at 6 weeks and rigorous sport at 12 weeks after 3 months. We did 50, now we did 20 patients, and we used the EFAS hindfoot score as the other used, and this was VAS and also pediographic data. We had more females than men, and the average age was 51. A third of our patients were diabetics. The average surgical time was 4 minutes. VAS score was decreased from 7 to 3 on average, and we see a marked improvement in pediographic data. The AFAS hindfoot score was improved from 64 points to 95 points on average, and there was a single complication of nerve injury that resolved eventually. We can see the pediographic data here. We can see that the patient does not step on the calcaneus on the affected side, and we can see that the difference between the healthy foot and the bad foot. After surgery, we get pediographic readings that is nearly the same. For conclusion, the advantages of our method is that it's minimally invasive. It's very, very easy to learn. The equipment is very minimal and cost effective. We use a single portal, a camera, and the smiley knife, which is very cheap. The incision is 8 millimeters compared to open procedure, which is for 4 to 10 centimeters of an incision. The infection rates are extremely low, and early control ambulation is achieved. Thanks.